Severe stable slipped capital femoral epiphysis is a pickle when it comes in when we're on call. And it's a pickle because there's alternatives. And broadly, there's two alternatives. We can pin it in situ, and by pinning it in situ, we're accepting the deformity, but we've got a very low risk of avascular necrosis. Or we can do a much bigger operation to correct the deformity, make the hip look amazing, but of course, risking avascular necrosis. So we know from the BOSS study, which was a big nationwide study of SCFE in the UK, we know that there's equipoise. We know that of those two approaches, half of the clinicians do one thing and half of the clinicians do the other thing. So we know there's genuine uncertainty about which of the two approaches we take in severe and also moderate stable SCFE. We also know there's the Montgomery ruling. So the doctor's got a duty to explain the material risks, which we're all really good at, and also explain the reasonable alternatives, which I guess we're not necessarily so good at. It's our job as doctors, and we're duty bound to explain that there's two treatments for this condition and that they're both reasonable treatments. Also, BigBOSS, the British Society of Children's Orthopaedic Surgery, have said that this is their top research priority. This is their top uncertainty. They're not sure what to do with severe stable SCFE of those two different approaches. We also know that NICE, the National Institute for Health and Care Excellence, have made recommendations, and they said that if you're going to do this, you need governance for research and audit. You need to put the patients in a registry. And when you start doing it, you need an experienced mentor in place. We also know that GIRF, the Getting It Right First Time path, or Getting It Right First Time program in the UK, have said that for uncommon major interventions in regions, we need pathways in place to make sure that these major interventions can get to specialty centres for the big interventions. So, and they mention in particular severe stable SCFE. So I'm going to give you a dream. I'm going to answer everything you want all together in a big study called the BigBOSS study. The BigBOSS study for NICE is giving you a governance structure. For Montgomery, it's proven that you've given patients the alternatives. For GIRF, it's making sure that your pathways work to get in the severe stable, the moderate stable SCFE to your specialty centre. And for BigBOSS, it's addressing your number one research priority. The plan, it's a superiority study, which means it's a really simple trial of pinning in situ versus the bigger operation of acute correction. The population's simple, it's nice and straightforward. It's 8 to 15 years old. They've got to be able to walk, so they have to be low to stable, with or without the use of crutches. So in reality, just be able to stand and get around a little bit. And the treating clinician needs to believe that this will be SCFE, which will cause significant femoroacetabular impingement. So look, I'm asking you to be a better boss in orthopedics. In fact, not a better boss. I want you to be a big boss in orthopedic surgery. Cheers.